A very good morning, respected and latest Chairperson, Mahatma Gandhi University of Medical Sciences and Technology, Dr. M.S. Swankar, Chairman cum Chancellor NGU MST, Dr. Vikas Chand Shwankar, Vice Chancellor Dr. Ajay Gulati, Pro Vice Chancellor Dr. V.K. Kapoor, Principal MGMCH Dr. M.D. Soni, Senior Faculty Members, colleagues and dear students. I welcome you all to the 17th Undergraduate Combined Rounds, topic for which is pain abdomen part 2 and we'll be covering cholecystitis. We will follow the contents of applied anatomy of liver and gallbladder, etiopathogenesis, clinical features, examination, management and complications of cholecystitis. Chairperson for these sessions are Dr. C.M. Agarwal, Emeritus Professor, Department of General Medicine, Dr. Paresh Kumar Sukhani, Professor and Head, Department of Radiodiagnosis, and Dr. Neel Kamal Gupta, Professor, Department of General Surgery. Starting off with today's session, I would like to invite Dr. Ajay Sharma, Professor and Head, Department of Surgical Gastroenterology, to give a brief introduction on the topic. Welcome, sir.
Good morning, everybody. Respected senior faculty, Swankar sir, teachers, and lovely students of MBBS students. I think today's topic is very, very valid for a few very important reasons. You know what is the most common surgery which was done almost 15-20 years back? 20 साल पहले it was appendectomy, which was most commonly done, and hernias. But today, the scenario has totally changed. It is done for cholecystitis more commonly, that is lap chole, which is more commonly done even than appendicitis nowadays. This all starts from gallbladder. So let me give you a brief introduction about gallbladder. The gallbladder term means, तो उसका original meaning है bile secreting substance. And I think now you will all know that by this time that is not bile secreting, it is bile storing substance. So this was a misnomer, but the term is still being used nowadays. कब identify हुआ gallbladder gallstones? Long back, 1500 years BC. जब मम्मीज के अंदर वो लोग abdomen open करते थे, they found there are stones in the gallbladder. और what they related was those people who are living by the river side, सब लोग नदी के पास रहते थे, कि वो लोग कुछ पत्थर खाते होंगे इसलिए इकट्ठा हो जाते हैं. That's how it was thought in Egypt. इसकी बड़ी अच्छी इंटरेस्टिंग स्टोरी एक और है कि वहां से चाइना में उन्होंने गॉलब्लैडर आइडेंटिफाई करा. That was in the firefighters who were in the army. उनमें जब उन्होंने गॉलब्लैडर जब एब्डोमेन ओपन करते थे तो उन्होंने कोरिलेशन का एक मिथ उनके साथ एक कोरिलेटेड है which is still proponent after USG कि जिनका गॉलब्लैडर बड़ा है he is a bigger warrior. तो कहते थे जो आदमी लड़के आया है he is a stronger fighter depends upon his gallbladder size. तो these were the myths which were associated. अगर कोई एक स्टूडेंट बता दे who did the first cholecystectomy, I think he needs to be important. सब लोग आज गॉलब्लैडर पढ़ के आए होंगे? नहीं. Who did the first lap chole? तो फर्स्ट जब तुम MS में जा रहे होगे तो एक लैंगनबैक रिट्रैक्टर आता है. लैंगनबैक was the first surgeon who did it in 1880s. The first cholecystectomy. Can you imagine? More than 150 years now. And then it became established in 1920 that gallbladder को लोगों ने accept करा. उससे पहले खाली drain डाला करते थे. Then subsequently something important in the history that first lap chole was done by Mohe, and lap chole was a turning point in gallbladder surgery. Anybody who can tell who did the first laparoscopic cholecystectomy in India? He is father of laparoscopic surgery in India.
Udwadia.
Yes. So it was Dr. Udwadia. It was JJ Hospital at Mumbai when the first lap chole was done. So I think that brief introduction tells us that what we are dealing with, it has had a long journey of gallbladder being identified, non-operative treatments till surgery. Cystitis means inflammation. Cholecystitis, inflammation, which we are going to discuss. So all inflammations usually lead to, we know, they lead to pain, inflammatory signs, and then so on. So we'll discuss on gallbladder. So thanks for this opportunity given to me. So I invite the next session, how to start it, please.
Good morning, esteemed dignitaries, respected teachers, and my fellow colleagues. I, Divya Thapar from batch 2021, stand before you to present the applied anatomy of liver and gallbladder along with my teammates Rishita Diwan, Akshit Khadab, Krishna Bhargava, and Navya Bhutani. Under the guidance of Dr. Pankaj Kumar Singh, Professor and Head of Department of Anatomy, and Moderator Dr. Prabjot Kaur Chhabra, Professor of Anatomy. Liver is the largest internal organ of the body which covers the whole right hypochondric region, most part of epigastrium, and extends to left hypochondric region. Its weight is about 1.7 kg in an average 80 kg man. Liver is anatomically divided into right and left lobes by falciform ligament. If we talk about falciform ligament, we should know that it provides orientation during cholecystectomy or liver resection surgeries and can also be used as grafts in liver and vascular surgeries as it contains some fat in it. It may contain accessory vessels which may bleed during surgeries. The ligaments help in fixing the liver are right triangular, left triangular, and coronary ligament that fix the respective lobes to undersurface of the diaphragm. The falciform ligament attaches the anterior surface of liver to the anterior abdominal wall. The anatomical division of liver has no such relevance clinically and surgically. Hence, the liver is functionally divided into right and left units along the Cantley's line. Cantley's line is an imaginary line which connects the gallbladder fossa to inferior vena cava. This line divides the liver into functional right and left lobes, and these units are more relevant to operative anatomy. There is one more division of liver according to Connor's classification. Liver is divided into 8 segments. Each segment is an independent functional unit as each contains its own branch of hepatic artery, portal vein, and bile ductule. The left functional unit comprises of segments 2, 3, 4A and 4B, and the right functional unit comprises of segments 5, 6, 7 and 8. Segment 1 is not included in any of these units. It is separate and called as caudate lobe. We will discuss the region behind this in further slides. The blood into liver is supplied by 2 vessels, portal vein and hepatic artery, of which majorly 80% of blood is supplied by portal vein and rest 20% by hepatic artery. Portal vein is rich in nutrients but low in oxygen, whereas hepatic artery is completely oxygenated. Portal vein is formed by union of superior mesenteric vein and splenic vein behind the neck of pancreas, and just before entering the liver it divides into 2 branches, right and left portal vein. The left portal vein supplies the left liver, and right portal vein further divides into right anterior and right posterior portal veins. The most common variation in portal vein distribution is portal vein trifurcation, in which portal vein directly splits into 3 branches: left portal vein, right anterior and right posterior portal veins. If we talk about hepatic artery, it arises from celiac trunk of aorta. Common hepatic artery further gives a branch, gastroduodenal artery, and now it becomes proper hepatic artery, which further divides into right hepatic and left hepatic artery that supplies right and left units of liver respectively. The segment 1 receives blood from both right and left portal veins and right and left hepatic arteries. Sometimes right hepatic artery directly arises from superior mesenteric artery, or left hepatic artery directly arises from left gastric artery. Liver drains the blood from each segment via hepatic veins into the inferior vena cava except the segment 1. There are 3 major hepatic veins: right hepatic vein, middle and left hepatic veins. All of them drain into inferior vena cava just below the diaphragm. Segment 1 directly drains into inferior vena cava. Porta hepatis is a transverse fissure on the visceral surface of the liver. It is the entry point for portal triad, contains 3 structures: branches of hepatic artery, portal vein and bile ductule. Knowledge of porta hepatis is very important in liver transplantation, resection and cholangiography. Liver forms the bile in hepatocyte cells and sends it to the gallbladder for concentration and storage. Now I would like to call Rishita Diwan to present the applied anatomy of gallbladder. Thank you.
Good morning, esteemed dignitaries, respected teachers, and my fellow colleagues. I am Rishita Diwan, and I am here to take you through the anatomy of the gallbladder. The gallbladder is a pear-shaped sac situated on the inferior surface of the liver, measuring from 7.5 to 12 centimeters in length. It serves as a reservoir for bile with a storage capacity of approximately 25 to 30 milliliters. It can be divided into three parts: the broader fundus part, the body, and the narrow neck part. Connected to the gallbladder is cystic duct, which is generally 3 centimeters long and 1 to 3 millimeters in diameter. An important feature here is presence of walls of Hester, which is spiral mucosal folds in cystic duct, which becomes a potential site of obstruction. Surrounding the wall of this duct is sphincter of Lutgens, which further regulates the flow of bile. When the cystic duct unites with the common hepatic duct, it forms the common bile duct, which opens into the ampulla of Vater, which is guarded by the sphincter of Oddi. It can sometimes become obstructed due to gallstones, pancreatic carcinoma, or enlarged lymph nodes. The obstruction results in impaired bile drainage, which will lead to obstructive jaundice. Now, the blood supply of gallbladder is majorly by cystic artery, which is a branch of right hepatic artery. It also supplies the upper part of the common bile duct. Now, you must be wondering, where do we find this cystic artery? So, it can be located in the Calyx triangle, which is highlighted in yellow on the screen. It is superiorly bounded by the inferior surface of the liver, laterally by the cystic duct, and medially by the common hepatic duct. The contents of this triangle include cystic artery, cystic lymph node of Lund. Now, sometimes an important anatomical variation is seen is Moynihan's hump, where the right hepatic artery forms a caterpillar-like loop. If it's not recognized by the surgeon, it may accidentally be injured, leading to profuse bleeding. So, to prevent such intraoperative complications, the concept of critical view of safety is employed. It is achieved by dissecting the Calyx triangle and exposing the cystic plate, ensuring that only two structures enter the gallbladder, which is cystic duct and cystic artery. An imaginary line called as the R4U line serves as the visual guide during cholecystectomy. It lies in the plane of Rouvier sulcus, the base of fourth segment of liver, and the umbilical fissure. Now, both the cystic artery and cystic duct lies above this line, and while the common bile duct will lie below this line. So, a surgeon must be careful to be above this line while operating to minimize the risk of injury to the common bile duct. Sometimes, when the patient of gallbladder pathology comes with the complaint of pain in abdomen, but also in the right shoulder. So let's understand why he experienced this referred pain in the right shoulder with the help of this slide on nerve supply. So the gallbladder receives sympathetic innervations from T7 to T9 spinal segments, often resulting in referred pain to the inferior angle of scapula, as it is supplied by the somatic fibers of the same spinal segment. The parasympathetic fibers from vagus nerve contribute to the epigastric pain, while the phrenic nerve is responsible for the pain at typically shoulder. With that, we conclude the anatomy of the gallbladder, and now I would like to call my fellow colleague Ashok Kumar upon the stage.
A very good morning to the esteemed dignitaries, respected faculty members, and my dear friends. Today, I, Ashok Kumar, present before you to explain the etiopathogenesis of cholecystitis. Sir, finally at 21 page. Yes, sir. Prepared along with my colleagues Aviral Bharti, Manshi Mishra, Meenu Bhukar, and Prakyam Jindal, under the guidance of Dr. Manju Raghav, Professor and Head, Department of Pathology, with moderator Dr. Meenu Gupta, Assistant Professor, Department of Pathology. Before moving to the cholecystitis, it's very crucial to understand the enterohepatic circulation of bile. Therefore, as bile is synthesized in the liver, from there it moves to the right and left hepatic ducts and then moves to the common hepatic duct. From there it released into the gallbladder through cystic duct. The gallbladder stores and concentrates the bile, and then this concentrated bile is released into the common bile duct under the influence of cholecystokinin in response to a fatty meal. It comes to the common bile duct through cystic duct and then move to the hepatopancreatic duct and finally released into the second part of the duodenum through sphincter of Oddi. And the lumen of the duodenum, it performs the emulsification of fats and helps in the absorption. Then the bile moves to the jejunum and ileum. in ileum, about 95% of the bile is reabsorbed in the capillary bed and move back to the liver through portal circulation. Cholecystitis. It refers to the presence of stones within the gallbladder or in bile ducts. That is choledocholythesis, where stones migrate into the bile ducts. Cholecystitis is one of the most common biliary pathology with significant surgical implications. These stones arise from the precipitation of bile components, primarily cholesterol, bilirubin, and calcium salts. When bile becomes supersaturated or when motility and mucin balance of bile gallbladder is disrupted. Now comes to the classification of gallstones. Gallstones are classified mainly into three types: cholesterol stones, pigment stones, and mixed stones. Pigment stones are again classified into two types of stones: black pigment stones and brown pigment stones. Let's first talk about the cholesterol stones. Cholesterol stones are named because they are primarily composed of crystalline cholesterol monohydrates, and this main component comprises from 50% to even 100% sometimes, along with bile salts, bile pigments, mucin glycoproteins, and phospholipids. They are pale yellow and radiolucent in morphology and are most common in Western populations. On the other hand, pigment stones are predominant in non-Western populations, and black pigment stones, which are found in sterile gallbladder bile, are composed of calcium bilirubinate, calcium phosphate, and calcium carbonate, and are radio opaque in nature. On the other hand, brown pigment stones are likely to be found in bile ducts and are composed of calcium bilirubinate, calcium palmitate, calcium stearate, and cholesterol. They are soft and radiolucent in morphology. Next, mixed stone. These comprises the features of both cholesterol stones and pigment stones, and are it's important to notice that they are most common type of gallstones overall. Etiology of cholecystitis. First one is biliary stasis, which is commonly seen in prolonged fasting, total parenteral nutrition, and in gallbladder hypomobility. Obesity and rapid weight loss, as seen in post-bariatric surgeries, causes supersaturation of cholesterol in the bile. Hormonal influence, increased estrogen, which is seen in pregnancy, oral contraceptive pills, and in hormonal replacement therapy, which increases the cholesterol secretion in bile. On the other hand, progesterone reduces bile salt secretion and gallbladder contractility. Hemolytic disorders like hereditary steatocytosis, sickle cell anemia, and thalassemia predominantly causes pigment stone formation. Infections caused by bacteria like E. coli and parasites like liver flukes, ascaris, etc. deconjugates the bilirubin, which leads to the formation of pigment stones. Conditions like cystic fibrosis favors the thickening of bile leading to the biliary stasis. And in conditions like cirrhosis, which alters the bile composition, aids in the process of pigment stone formation. In case of ileal disease or ileal resection, bile salt resorption is decreased, resulting in cholesterol supersaturation of bile. And certain drugs like ceftriaxone and octreotide also act as etiological factors for the formation of gallstones. Next comes the pathogenesis of gallstone formation. As we have earlier seen that cholesterol stones are predominantly composed of cholesterol. Therefore, let's see about their formation first. Naturally, cholesterol is insoluble in bile. Therefore, cholesterol becomes soluble in bile by micelle formation with bile salts and lecithin-like phospholipids, both of which act as detergents. Now, whether the cholesterol remains in solution or not, it depends upon the type and relative concentration of bile salts and phospholipids in the bile. Therefore, when cholesterol level exceeds the solubilizing capacity of bile, that is beyond 4:1 ratio of cholesterol with bile salts, supersaturation occurs, and by this, cholesterol can no longer remain dispersed in the solution and precipitates as crystalline monohydrates. Along with this, low motility leads to the prolonged contact time between cholesterol and mucosa, which favors crystals formation, and nucleation of cholesterol into solid crystals. It's important to note that it's an early step in the stone formation. And the next step is hypersecretion of mucin in gallbladder. This leads to the excessive mucus, which traps nucleated crystals and leads to the accretion of more cholesterol, ultimately leading to the appearance of macroscopic stones, which may remain silent or cause biliary obstruction. Next come the pigment stones. Black pigment stones are formed because of increased bilirubin levels, unconjugated bilirubin levels in bile, which are often seen in hemolytic disorders. And now this unconjugated bilirubin precipitates and combines with calcium to form calcium bilirubinate, the primary component of pigment stone. This leads to the formation of hard black stones. Next is brown pigment stones. Are formed due to the bacterial or parasitic infection of the biliary system caused by organisms like E. coli, Ascaris, liver flukes. As this infection increases the amount of unconjugated bile through the release of microbial beta-glucuronidase which hydrolyze bilirubin glucuronides, and this leads to the formation of soft greasy stones, brown stones. Thank you. Next, I would like to call Asta to carry forward the presentation.
Good morning, respected dignitaries, teachers, and my fellow colleagues. I, Asta Punia from batch 2021, will be presenting the clinical features and examination of cholecystitis. This presentation has been prepared by my team, Priyakshi Saini, Apurva Mathur, Abhinav Gautam, and Akshat Patni, under the guidance of Dr. Sanjay Singhal Sir, Professor and Head of Department of General Surgery, and moderatorship of Dr. Neel Kamal Gupta Sir, Professor and Unit Head of Department of General Surgery. Clinical symptoms are what patient reports he feels, and signs are what the examiner elicits. Symptoms of cholecystitis include pain, which start in the right upper quadrant and may radiate to the right shoulder. It may be sudden or insidious and usually gets triggered or aggravated following fatty meals. Pain is severe, steady, continuous, and described as deep, dull, gnawing. Colicky pain is seen in cases of biliary colic. Pain in cholecystitis persists for hours to days, whereas in case of biliary colic, the pain is short-lived. It can worsen with deep breathing, movement, or pressure, and usually not relieved by vomiting or rest. Often accompanied by fever and chills, nausea and vomiting, mild jaundice if associated with obstruction, dyspepsia or flatulence. Signs of cholecystitis. Right upper quadrant tenderness in acute cholecystitis. Tenderness is present just below the tip of 9th costal cartilage on the lateral margin of right rectus. Muscular guarding rigidity, that is involuntary tensing or stiffness of the abdominal muscle in the right upper quadrant. Fever, tachycardia, Murphy sign and Boas sign, which will be explained in later slides. Jaundice in complicated cases. Courvoisier-Terrier sign or Courvoisier's law states that a palpable gallbladder in presence of jaundice is seldom due to stone. The signs suggest malignant obstruction as seen in carcinoma of head of pancreas, cholangiocarcinoma, ampullary carcinoma. Abdominal distension is less common in uncomplicated cholecystitis. Palpable gallbladder is rare. In some cases of cholecystitis, the gallbladder may be palpable during physical examination, especially in thin patients where less abdominal fat allow easier detection. This occurs when the gallbladder becomes inflamed and distended, usually due to a cystic duct obstruction caused by gallstone. The trapped bile duct and increasing pressure causes the organ to enlarge and become tender. A palpable gallbladder may also be observed in acalculous cholecystitis, often seen in critically ill patients, and can be a serious complication of other medical or surgical conditions. In general physical examination, we will first look at the general appearance. Then we will observe attitude. Patient may show signs of discomfort or facial grimace. He may be lying still and breathing shallow to avoid movement-induced pain. He may be guarding the right upper quadrant. In pulse, we check the rate, rhythm, and depth of breath. We will measure the temperature of the patient. Commonly, mild to moderate grade fever is observed. Dry tongue is indicative of dehydration. Cyanosis points to hypoxia, while pallor may be suggestive of anemia. Lymphadenopathy indicates infection or malignancy. Examination of abdomen will be done in following steps: inspection, palpation, percussion, and auscultation. In inspection, explain the procedure and take consent from the patient. The patient should lie flat on his back with legs extended. Whole abdomen from the nipple above down to the saphenous opening must be exposed. In inspection, we will observe the skin over abdomen, look for redness, distension, scar from previous surgeries, or dilated veins. The contour of abdomen, see if abdomen is flat, rounded, scaphoid or distended. Check if the quadrant of abdomen is moving equally with respiration. In cholecystitis, the right upper quadrant may show reduced movement due to pain. Notice the peristaltic movement. Look for any pulsating swelling, particularly in epigastric region. Inspect all hernial orifices and external genitalia. Palpation. Patient lie in supine position with knees slightly flexed to release tension in abdominal muscles and relaxing them. A relaxed abdominal muscle allows deeper palpation and better identification of masses, organomegaly, rebound tenderness, etc. Ask patient to breathe from mouth. Make sure you do not hurt the patient by palpating too deep or too roughly. Otherwise, abdominal muscle go into spasm and important findings can be missed. All findings of inspection are confirmed by palpation. We feel any localized or general rise in temperature using the back of our hand. This may indicate inflammation, infection. Check for tenderness. This helps in identifying the affected organ or quadrant. Check for hyperesthesia. Muscular guarding and rigidity may indicate peritoneal irritation. Test for rebound tenderness as it is indicative of peritonitis. Feel for any palpable lump and note their size, consistency and mobility. Palpate any hernial sites present. This video demonstrates superficial palpation. For this, we palpate the abdomen about 1 cm deep and observe any abdominal facies. This is done to note any tenderness and muscular guarding. Superficial palpation is followed by deep palpation. For deep palpation, we depress the abdominal wall 4 to 5 cm deep and check for rebound tenderness. It indicates peritoneal inflammation. Murphy's sign. It is a clinical test used to detect tenderness in cholecystitis. Place the right hand just below the right costal margin on the lateral border of the right rectus and apply moderate pressure with fingers. It is considered positive when the patient suddenly halts inspiration due to pain. This indicates an inflamed gallbladder coming in contact with your palpating fingers. Boas sign. It is a clinical test used to assess for acute cholecystitis. It is characterized by hyperesthesia in the area between 9th and 11th ribs, posteriorly on the right side. For palpation of liver, ask the patient to take a deep breath as we place our right hand flat on the right iliac fossa with fingers pointing towards right costal margin. During inspiration, press gently and move upwards. Notice the consistency, surface, borders and size of liver. Also, observe presence of tenderness anywhere. In percussion, we will be observing obliteration of liver dullness, shifting dullness, fluid thrill. Liver dullness. In liver dullness, percussion is done from the chest resonant area downward along the right mid-clavicular line. The note changes from resonant to dull at the upper border of liver around 5th intercostal space, and the dullness continues till the lower border near the costal margins. This helps in assessment of liver size. If dullness is replaced by resonant note, it indicates the presence of free gas under diaphragm. It may indicate perforation of gastrointestinal tract. Shifting dullness. It is a clinical test used to detect free fluid in the abdomen. In this video, we are percussing the abdomen from center to flank and noting a shift in the area of dullness. When the patient changes position, we wait for 15 minutes to let the fluid shift. Conditions in which free fluid can be accumulated in peritoneal cavity are perforated peptic ulcer, acute pancreatitis, ruptured ectopic gestation. Fluid thrill. It is a test for detecting large amount of ascitic fluid in the abdomen. A tapping impulse on one flank is transmitted to the opposite side and felt by examiner's hand, indicating free fluid. Auscultation of the abdomen is done for detecting bowel sounds and vascular bruits Succession splash sound is heard in gastric outlet obstruction via stethoscope. Differential diagnosis of cholecystitis, biliary colic. In biliary colic, intermittent right upper quadrant pain without fever or localized tenderness is seen. In acute pancreatitis, epigastric pain radiating to the back, elevated amylase lipase. In peptic ulcer, pain is epigastric, burning, and food related. Appendicitis may present with right upper quadrant pain. Pain usually migrates from periumbilical region. Now, I would like to call my fellow colleague Swechha Goyal to take the presentation forward.
Good morning, esteemed dignitaries, respected faculty members, and my fellow colleagues. I, Swechha Goyal from MBBS batch 2021, stands before you to present radiological investigation of cholelithiasis as a part of undergraduate combined rounds with my teammates Gunjan Devasi, Aman Kumar, Sonia Agrawal, and Sonal Agrawal under the guidance of Dr. Paresh Kumar Sukhani, Professor and Head of Department of Radiology, and Dr. Tushar Prabha, Professor and Department of Radiology. Cholelithiasis, a common yet potentially serious condition, called for timely and accurate diagnosis. In this presentation, I will be highlighting the pivotal role that modern imaging technique plays, not only in the detection but also in guiding therapeutic decisions. From basic ultrasonography to advanced modalities like MRCP and CT, we will explore how radiology shapes patient outcome in gallstone disease. Ultrasonography, USG's imaging modality of choice in case of cholelithiasis. Advantages of USGR: it is non-invasive, readily available, and quick to perform. Disadvantages of USGR: it is operator dependent, difficulty in diagnosing if fat or intraluminal gases are present. Finding in the USGR: size and shape of the gallbladder. Usually, gallbladder is pear-shaped with size of 7.5 to 12 centimeters long. This is a normal gallbladder image. Pericholecystic fluid can be visualized in USG as anechoic or hypoechoic rim around the gallbladder wall. Inflammation around the gallbladder usually associated with cholelithiasis. Wall thickness of the gallbladder is normally less than 3 mm, which can be seen in the image A. As we can see in this image B, there is a pericholecystic fluid showing fluid-like echogenicity with increased wall thickness due to stone obstructed in it. Stones in the gallbladder on USG appear as hyperechoic with posterior acoustic shadowing, and the image B depicts stone in the neck of the gallbladder. Now, the stone in the neck of the gallbladder can be impacted or non-impacted. That can only be known by changing the patient's position to left lateral and then to prone. The impacted stone will be immobile on changing patient's position. Next, we can see is polyp, common bile duct diameter, and stones in the hepatic biliary tree on USG. The image A is showing normal gallbladder with dilated CBD stones in it, and the image B is showing polyps in the gallbladder. Polyp and stone can be differentiated as polyp are immobile and stones can be mobile. Polyps are less hyperechoic while stones are more hyperechoic. Endoscopic ultrasonography mainly helps in the diagnosis of cholelithiasis and diagnosing and staging in cancers of pancreas and periampullary region. X-ray abdomen. However, X-ray is not a modality of choice in case of gallstone, but we can still visualize 10% of the stones which are radiopaque due to calcification and radiolucent C present in it. Have a look at this picture. This is showing typical Mercedes-Benz sign due to radiolucent gases present in it. The image B is of porcelain gallbladder, which is basically showing calcification of gallbladder, and the image A is of emphysematous cholecystitis, which is showing clear intramural and pericholecystic gases, which is representing classical radiographic appearance of emphysematous cholecystitis. Computed tomography. Only 75% of the gallstones are detected by CT. It is not used as a modality of choice in gallstones, but it is a modality of choice in diagnosing and staging of cancers of liver, gallbladder, bile duct, and pancreas. The image A is showing axial CT of abdomen with normal gallbladder, while image B is showing axial CT of abdomen with hyperattenuated stones in it. Magnetic resonance cholangiopancreatography. It is a non-invasive modality that provides excellent imaging of the gallbladder and biliary system. Take a look at this image. This is showing normal biliary tree with intrahepatic bile duct, common bile duct, pancreatic duct, and duodenum. First image is showing dilation of the biliary tree due to higher obstruction, and the second image is showing multiple filling defects with dilated common bile duct. Hepatobiliary immunodiacetic acid scan, that is HIDA scan. Used mainly in the post-operative settings to assess the functionality of the gallbladder by injecting immunodiacetic acid dye And if it fails to fill the gallbladder after 2 hours, that will indicate obstruction in the bile duct due to acute cholecystitis. Thank you. Next, I would like to invite Subhoshmita Burman to present medical management of cholelithiasis.
What is the difference in ERCP and MRCP?
Sir, ERCP is endoscopic retrograde cholangiopancreatography, while MRCP is magnetic resonance cholangiopancreatography. ERCP is also used as treatment modality and it is invasive, while MRCP is non-invasive.
Good morning, esteemed dignitaries, respected faculty members, and my fellow colleagues. I, Subhoshmita Burman, final year batch 2021, stand before you to present the medical management of cholecystitis, co-prepared by Jay Badnawat, Harsh Indra, Tushar Gatela, and Chetna Singh, under the guidance of Dr. Puneet Rijwani, Professor and Head of Department General Medicine, and moderated by Dr. Pradeep Agarwal, Professor and Unit Head Department of General Medicine, and Dr. Janendra Jain, Senior Resident Department of General Medicine. As anatomy, etiopathogenesis, clinical features, and radiological aspects of cholecystitis have been discussed by the previous presenters, now we will take this presentation forward and discuss its management. Cholecystitis, calculus or acalculus. It is a common cause of abdominal pain and hospital admissions in India, results from gallbladder inflammation. It is due to gallstone obstruction, also known as calculus cholecystitis, or may be due to any other underlying cause, also known as acalculous cholecystitis. Acalculous cholecystitis. Acute and chronic inflammation of the gallbladder can occur in the absence of stones and give rise to a clinical picture similar to that of calculous cholecystitis. Some patients have non-specific inflammation of the gallbladder, whereas others have one of the cholecystosis. Acute acalculous cholecystitis is particularly seen in critically ill patients and those recovering from major surgery, trauma, and burns. The diagnosis is often missed and the mortality rate is high. The treatment starts with resuscitation and general supportive care with broad spectrum intravenous antibiotics. In complicated cases, surgery is preferred. Cholecystosis. This is a relatively uncommon group of conditions affecting the gallbladder in which there are chronic inflammatory changes with hyperplasia of all tissue elements. They are as follows: cholecystitis or strawberry gallbladder, cholesterol polyposis of the gallbladder, cholecystitis glandularis proliferans or adenomyomatosis, diverticulosis of the gallbladder, typhoid infection of the gallbladder, dengue, gallbladder polyps, and xanthogranulomatous cholecystitis. Experiences show that in more than 90% of cases, the symptoms of acute cholecystitis subsides with conservative measures. They are as follows: hospital administration is required for continuous monitoring of vitals and comprehensive supportive care, bowel rest to minimize gallbladder stimulation and inflammation. Intravenous fluids are essential for hydration and correcting electrolyte imbalances, preferably by crystalloids such as ringer lactate or normal saline. Pain control is administered by analgesics such as non-steroidal anti-inflammatory drugs or opioids as needed for patient relief. And anti-emesis is achieved by nasogastric tube to manage nausea and vomiting, ensuring patient comfort. Initial medical management focuses on stabilizing the patient and alleviating symptoms. This foundational approach prepares patient for further treatment, whether medical or surgical. Antibiotics. To treat low-risk infections, the single-agent regime includes piperacillin and tazobactam. The combination regime includes one of the following drugs, namely cefazolin, cefuroxime, cefotaxime, ceftriaxone, and ciprofloxacin, along with metronidazole in their respective doses. To treat the high-risk infections, the single-agent regime includes imipenem, cilastatin, meropenem, doripenem, and piperacillin tazobactam. In combination regime, one of cefepime and ceftazidime are preferred along with metronidazole in the respective doses. Now I will call Jay Badnawat to explain the surgical management of acute cholecystitis. Thank you.
Morning, respected dignitaries, respected faculty members, and my dear friends. Today, Ajay Sharma from MBBS Batch 21 will take this PPT forward and explain the surgical management of cholelithiasis or cholecystitis. Cholecystitis, whether it is at the very first assessment, we assess whether the patient is symptomatic or asymptomatic with gallstones. Asymptomatic gallstones do not need intervention. However, prophylactic cholecystectomy may be performed for asymptomatic cholelithiasis in the following situation. That is large gallstones, that is the size is greater than 3 centimeters, cholelithiasis, chronic hemolytic conditions like sickle cell disease or hereditary spherocytosis, gallbladder polyps greater than 1 centimeter in diameter, suspicion or risk of malignancy, that is anomalous pancreatic ductal drainage, calcification of the wall, that is porcelain gallbladder. Some ethnic groups or subjects living in the areas with a high prevalence of gallbladder cancer associated with gallstones, like in some parts of northern India, Native Americans, Mexican Americans, Colombia, Chile, or Bolivia, in transplant patients and in bariatric surgery. Now we come over to the management of symptomatic gallstones. For patients with symptomatic gallstones, cholecystectomy is the treatment of choice, and if there are no medical contraindications. Now, what are the surgical approaches for cholecystectomy? There are two surgical approaches for cholecystectomy. The laparoscopic cholecystectomy, which is the gold standard approach. The other is open cholecystectomy, which is a good old method. For patients in whom laparoscopic approach is not indicated or in whom conversion from a laparoscopic approach is required or appropriate facility of laparoscopy is not available, then open cholecystectomy is also performed. In this, an upper midline incision or short subcostal, that is the Cocker incision or right upper transverse incision is made, centered over the lateral border of the rectus muscle. Now, what are the preparations for a cholecystectomy? After appropriate history taking and assessment of the patient's fitness for the procedure, routine laboratory investigations, which include a coagulation screen, complete blood count, random blood sugar, serum amylase and lipase, and liver function test should be checked. The patient must sign a consent form to indicate that he or she is fully aware of the procedure being undertaken, the alternative options and the risk involved, including complications that may occur. Prophylactic antibiotics should be administered at the time of induction of anesthesia. A second generation cephalosporin as appropriate. Subcutaneous heparin and anti-embolic stocking should be prescribed. The various factors identified as predictors of difficult cholecystectomy and the risk factors for presence of CVD stones are explained in the further slides. Now, what are the risk factors for a difficult cholecystectomy? Factors related to history, like if the patient is male or his age is more than 65 years, interval between the onset and presentation is more than 72 to 96 hours, and acute cholecystitis, previous multiple attacks, previous upper abdominal surgery, prior attempt at cholecystectomy. Factors related to physical examination, if the patient has morbid obesity or any other comorbid conditions present, which is evaluated by the ASA score. Factors related to laboratory tests, like if the patient has abnormal liver function tests. Factors related to imaging, if the patient has thick gallbladder that is larger than 4 to 5 mm. Contracted gallbladder, distended gallbladder with impacted stones in the neck, gangrenous gallbladder or gallbladder perforation, Meniere's syndrome, cholecystoenteric fistula, cirrhosis or extrahepatic portal vein obstruction, that is portal cavernoma with portal hypertension. Intraoperative factors, like if the patient has a shrunken gallbladder, liver is retracted with fissure or depression occurring near the fundus, or fatty or firm cirrhotic liver as it causes difficulty in retraction. Now, what are the important operative steps during the cholecystectomy, which are explained in this next slide. Now, here is a videographic representation of important steps of cholecystectomy: the port placement of epigastric port, working port, and the retraction port under vision. After that, the gallbladder's peritoneum is dissected posteriorly and anteriorly using an L hook. Next, the critical view of safety is achieved by seeing two and only two structures entering the gallbladder, that is the cystic artery and cystic duct, with the background of liver bed. And only after the achievement of critical view of safety, that is CVS, the further clipping and cutting of cystic artery and cystic duct is done to extract the gallbladder in an endobag. Now, what is the purpose of achieving the CVS? Any difficulty in achieving the CVS is a warning. Further dissection may be hazardous with increased risk of biliary or vascular injury. The surgeon should immediately stop and reconfirm with the team or a second surgeon that the CVS has been achieved. Now, what are the complications during cholecystectomy? Bile leak, which is most common, infection, surgical site infection, and hernia, which are a rare complication, bleeding, bile duct injury, which is most common, Complication: post-cholecystectomy choledocholithiasis and stricture of bile. And as you can see, there is a schematic representation of Strasberg's and Bismuth's classification of bile duct injuries. With this, I would like to call the next presenter, Jayant Yadav, to take this PPT forward. Thank you so much.
Respected dignitaries, esteemed faculty members, and my fellow colleagues, I, Jayant Yadav, along with the help of my team members, Adhar, Aman, Ananya, and Divyanshi, I'm here to present our topic, Complications of Cholecystititis, under the guidance of Dr. Sanjay Singhal, Head of the Department of Surgery, and Dr. Neel Kamal Gupta, Professor and Unit Head of the Department of Surgery as part of the 17th UGCR. To begin with, cholecystititis or gallstone disease can result in a range of complications if left untreated or poorly managed. In this presentation, we will discuss these complications under the following headings with an aim to understand the pathogenesis, clinical features, investigations, and management of each complication. With this in mind, let's first look at a very common clinical presentation, biliary colic. A biliary colic results from transient obstruction of the cystic duct, typically after a fatty meal, which causes contraction against the blockage and leading to pain. Patients typically present with sudden severe right upper quadrant pain or epigastric pain, which may radiate to the right shoulder or scapula. The pain usually resolves within a few hours as the stone dislodges. Investigations primarily involve an ultrasound scan, which shows gallstones without signs of inflammation. Management includes pain control using NSAIDs or opioids if the pain is too severe. Elective laparoscopic cholecystectomy is recommended to prevent recurrence. We now move on to an inflammatory complication, cholecystitis. Cholecystitis, both acute and chronic, result from persistent cystic duct obstruction, leading to biliary stasis, inflammation, and eventual fibrosis in chronic cases. Patients commonly present with right upper quadrant or epigastric pain, fever, and a positive Murphy sign, which is indicated by pain and an abrupt halt in inspiration as an examiner palpates the region overlying the gallbladder. Ultrasound scan typically reveals gallbladder wall thickening, often more than 3 millimeters, and presence of pericholecystic fluid as depicted by the arrow in the image shown. Lab findings may include leukocytosis, an elevated CRP level, and an abnormal liver enzyme pattern. Management includes early laparoscopic cholecystectomy with analgesics and antibiotics administered as needed. Unresolved gallstones may progress to a suppurative condition known as an empyema. Empyema of the gallbladder occurs when there is superinfection with organisms such as E. coli, Klebsiella, Clostridia, or Bacteroides, leading to pus accumulation. Patients typically present with marked right upper quadrant pain and a high-grade fever. Diagnosis is confirmed through ultrasound or CT scan, and laboratory findings will show leukocytosis and elevated inflammatory markers. IV antibiotics targeting gram-negative anaerobic bacteria are administered urgently, followed by an early cholecystectomy or a percutaneous drainage or cholecystostomy in high-risk patients. Talking about mucocele, it results from cystic duct obstruction without superinfection, which leads to mucus accumulation inside the gallbladder and distension. Clinically, it is often asymptomatic or may only present with mild discomfort, sometimes accompanied by a palpable, non-tender mass in the right upper quadrant. Ultrasound scan shows an enlarged fluid-filled gallbladder, as can be seen in the image, without stones or any signs of inflammation. A mucocele may be managed through elective cholecystectomy to prevent any further complications. Perforation typically follows necrosis of the gallbladder wall due to prolonged inflammation. It may lead to a localized abscess or generalized peritonitis. Key clinical features include a sudden worsening of pain with possible signs of sepsis and peritonitis such as tenderness and guarding. A CT scan is the investigation of choice and may reveal fluid collections or abscess formation. Emergency surgical intervention is required, often in the form of abscess drainage and open cholecystectomy. A complication involving the biliary tree is choledocholithiasis. This condition arises when the gallstones migrate from the gallbladder into the common bile duct, causing biliary obstruction and may even lead to ascending cholangitis if an infection supersedes. Clinical presentations include right upper quadrant pain, jaundice, and the classical Charcot's triad of intermittent fever, intermittent jaundice, and intermittent pain. In severe cases, additional hypotension and altered mentation together with the Charcot's triad may make what's known as a Reynolds pentad. Investigations include liver function tests, which show elevated direct bilirubin.
चारकोट्स ट्रायड एंड रेनॉल्ड्स पेंटेड है, ये शॉर्ट नोट्स में आ जाते हैं, इनको आप सब अच्छी तरह से याद रखें, ठीक है।
Investigations include liver function tests showing elevated direct bilirubin levels and gamma glutamyl transferase levels, and imaging modalities such as magnetic resonance cholangiopancreatography or MRCP, or a more invasive endoscopic retrograde cholangiopancreatography or an ERCP. The ERCP is also used as a therapeutic modality along with stone extraction, and which may also be followed by a cholecystectomy. A potentially serious complication, gallstone pancreatitis, results from transient ampullary duct obstruction, triggering enzyme activation and pancreatic inflammation. Patients often experience epigastric pain which radiates to the back and may be relieved by leaning forward. Additional signs include nausea, vomiting, and systemic features such as tachypnea and tachycardia may also be present. Lab findings will show elevated amylase and lipase levels, and a contrast-enhanced CT is the best diagnostic tool, showing enlarged pancreas and signs of biliary obstruction. Management is supported initially, including fluids, analgesia, and adequate bowel rest. ERCP is considered if biliary obstruction persists, and a cholecystectomy is performed subsequently. We will now discuss gallstone ileus. It's a condition that arises from chronic inflammation which creates a fistulous connection between the gallbladder and the intestine, also known as a cholecystoenteric fistula. Large stones may pass into the bowel through this fistula, causing mechanical obstruction, most commonly at the ileocecal valve. It primarily affects elderly people and presents with vomiting, abdominal distension, and an intermittent colicky pain, which is also described as tumbling obstruction. Radiological investigations include CT imaging, which demonstrates the regular striae, pneumobilia, or air in the biliary tree, shown by the arrow image. Small bowel obstruction seen as dilated loops of small intestine, and an ectopic gallstone seen as a radio-opaque shadow, commonly but not always in the right iliac fossa. Treatment involves enterolithotomy with cholecystectomy and fistula repair as needed. Lastly, we have Merizzi syndrome, a rare yet a serious complication. Merizzi syndrome results from a stone impacted in the cystic duct or the gallbladder infundibulum, compressing the common hepatic duct or the common bile duct externally. It may also lead to possible fistula formation. Patients present with right upper quadrant pain and obstructive jaundice. Lab findings include elevated bilirubin levels, and imaging with MRCP or an ERCP may show the classical meniscus sign. Management involves preoperative ERCP along with stent placement, followed by cholecystectomy, which may be open or laparoscopic depending on the type of the condition. To summarize, cholelithiasis may lead to a wide spectrum of complications, from biliary colic to potentially life-threatening conditions such as pancreatitis. Timely diagnosis and appropriate surgical and supportive management are crucial to prevent mortality and morbidity. Thank you.